Welcome to Season 3 of Derms on Drugs, a video podcast brought to you by Scholars in Medicine, the best educational platform in dermatology and provided at no cost to medical providers. Derms on Drugs is where cutting-edge derm meets serious comedy. I'm Dr. Matt Zires from Doc's Dermatology, and each week I'm joined by my residency buddies, Dr. Laura Ferris from the University of North Carolina and Dr. Tim Patton from the University of Pittsburgh, and we use our 60 years of combined derm experience to discuss, debate, and dissect the hottest topics in dermatology. It is everything you need to know to be on the cutting edge of derm, and you'll actually have some fun listening. New episodes drop every Friday on Scholars in Medicine, Apple Podcasts, Spotify, and other major podcast platforms. And I highly, highly recommend that you download the Scholars in Medicine app to access the full podcast video archive, explore the best derm educational content out there, not this pharma-generated crap, but actual real bread and butter dermatology. And it's all supported by an amazing clinical consultant called Ask Simon. So before we get into our episode today, I just have to let our listeners know to keep Dr. Patton in your prayers. He is going to have open heart surgery later this summer. It's actually the first of a series of 3 procedures. Turns out they can only make your heart one size larger at a time. But no, actually he is having heart surgery. He has to have a aortic valve replacement. Dr. Patton, we'll all be wishing you the best, Dr. Patton.
I appreciate that. Anything helps, I suppose.
Okay.
We'll make you record from the hospital room. It's okay. We're not missing an episode over this. You're not getting out that
I can hear it now. Turn down his pain meds. He needs to be a little more. All right, Ferris, what do you got?
Okay, so my first 6-pack article is from the British Journal of Dermatology, weekly versus daily bathing for people with eczema, results of the eczema bathing online randomized controlled trial, Bradshaw et al. So I guess they get to call it eczema and not atopic dermatitis because they probably don't have such a hard time with prior auths like we do, or we have to give it official name. Okay. So, this is kind of interesting. Like we make patients feel like, oh my God, don't wash your skin too much. You're going to get dry, but otherwise you're going to be full of staph. So maybe take showers more. And, does it really matter? Who's going to do this clinical trial? Certainly not me. Nobody's going to get funded. So what they did was this was actually a pragmatic online recruited randomized trial in the UK. So, how did they get patients for this? They recruited them on social media, eczema support networks, text, general practice. And so people basically signed up to say, I'd like to be part of a clinical trial on bathing. So they screened about 880 people, 438 were ultimately randomized. So 218 to 20 per arm. So kind of, a good number. And they were randomized either to bathe every single day or bathe once a week. And I was like, those are kind of 2 extremes, right? Maybe every other day would have been a nice arm, but that was not it. And so,
was it
people
blinded?
Agreed to it.
Was it double blinded? Did the patients know how often they were bathing?
All right. They put them in the shower and just made noise.
Exactly. They did point out that this was not a double blinded. They washed them with placebo water, which was actually like orange juice. It was tough, but no, there was no blinding. And so the baseline was that people, you're like, how often do people shower? Apparently 4.3 times per week. So they had to do either more or less. And so people were actually pretty good in terms of when you ask them, how adherent were you? Basically, the adherence was 62% of people were adherent with it. So that would mean that maybe they, missed a shower or 2 or, couldn't handle it and had to take an extra bath. Why did they do it? It was either my skin's too dry, I can't do this every day, or gosh, my skin feels gross, or I worked out and I didn't want to wait 5 more days to shower. So kind of the, what you would expect. So what was the efficacy? So their primary outcome measure was the POEM score. And so basically, this was all sort of patient reported. There was no easy scoring or things like that. There was no difference. So weekly showering, daily showering, 0 difference in the poem score. No, it was a 4-week endpoint. This wasn't like 16 weeks. There was no like crossover arm or anything. There was no difference in itch. There was no difference in quality of life. Basically, shower however often you want to shower. There was no difference. So, why was this kind of cool? Like, it was basically an online shower. There were like citizen scientists. So the patients, had input into the design of the study. And,
Darcy, are you going to try and you're going to try and recruit some of those citizen scientists to be faculty in UNC?
Yes, because I don't have to pay them. I love faculty I don't have to pay. That's my whole goal as a chairs. How many people can I get to do work for as little money? That's not true at all. I don't do that at all. I pay my faculty well and advocate for them to be paid well because they work incredibly hard. So
that's right.
Basically kind of cool. Answer. Now we've got some data to guide us on how often people should bathe, and it doesn't matter. Do what you want.
My favorite part of this article was when you look at the like forest plot of where the like whatever the people who thought that bathing daily was good for eczema, it worked amazingly for them. Amazingly.
Yeah. And the people who thought that bathing weekly was better, they tended like they were in that arm of favors weekly bathing. Yes. So it just goes what patients think tends to be what works better for them.
And that I will say that is honestly what I tell eczema patients, when they're like, well, what moisturizer should I use? And I'm always like, if you think it helps, put it on. If you don't think it helps, it doesn't really matter. Try, different brands. Everybody's different in terms of which one they like. Usually CeraVe works the best, but everybody's different, blah, blah, blah. Because
but you were also in a commercial for them, so there is that. That might be it.
They only ran that commercial like 3 times, so I'm kind of mad about it.
Mostly in like South America, I think. But yeah.
Yeah, they dubbed them. They overdubbed them. Hola. Mi chiamo Maturizaitis.
But so because if you tell them like you have to moisturize, that makes them less compliant with the stuff that really does help. Like we know the more stuff you tell people to do, the less stuff that they actually end up doing. So that's okay.
No, if people don't buy in, then it doesn't work. So it was a good reminder of that. But yes, doesn't matter how often you bathe. Do what you believe in and it will work the best for you.
That's right. That's right. It's all relative. There's no truth.
Exactly.
All right. Let's move on. Patton, what do you got? Let's give us some truth.
My first 6-pack paper is from the March 2026 JAMA Oncology and is titled Morbidity and Mortality Outcomes of Dupilumab for Cutaneous Immune-Related Adverse Events by Block et al. So some background, there's a 2025 paper in Journal of Immunotherapy of Cancer, retrospective study done at Mass Gen and Dana-Farber, I think, that compared patients with bad, I'm going to call it ICI, immune checkpoint inhibitor rashes, that got Dupi to 2 other cohorts, patients that got bad ICI rashes and didn't get Dupi and patients that didn't get bad ICI rashes. So take-home points from that previous study were that Dupi worked, like close to 90% of patients had complete or partial responses, and there was no statistically significant difference in mortality between the groups. High-dose steroids associated with worse outcomes, blah, blah, blah. So the current paper is a Trinetics study, so not believable at all, we're thinking. The authors took patients with ICI rashes that got Dupi and compared them to 2 groups. They compared them to patients with ICI rashes that didn't get Dupi and patients with ICI rashes that got systemic steroids. Propensity matched scoring done to match patients for a bunch of stuff. And the primary endpoint was all-cause mortality at 5 years. And the results are represented in the figure, just one figure, a couple tables, one figure. Just kind of crazy, absurd hazard ratios, right? 0.24 compared, Dupi compared to non-Dupi, 0.31 versus the steroid controls. So that's like close to 80%, 70% improved mortality if you got Dupi for an ICI rash. They reran the data with the sensitivity analysis. Still kind of crazy hazard ratios for mortality. So yeah, I mean, it's not believable. I could see where Dupy might help a little bit. And I don't think it's really the fault of the authors. I think all the statistics probably check out. It's just that I don't think Trinetics is providing anyone with like realistic data.
I've got an alternative explanation coming, Patton.
Oh, let's hear it.
Okay, so we're going to segue into my segment of the six pack. So this was a study which I had never really seen this before. The effect of pre-existing atopic dermatitis on clinical outcomes of immune checkpoint therapy. And so having AD made immune checkpoint. Now, this was also a Trinetic study, so I gotta be honest. It could all still be baloney. But having pre-existing AD made you much more responsive to immune checkpoint inhibitor therapy. So they had a much higher rate of getting the adverse events. So 5.93 hazard ratio of getting a cutaneous immune-related event, increased rate of endocrine events, increased rate of GI events, but they had better substantially overall survival. So let's see here. Pre-existing AD had lower all-cause mortality, 0.56. So you were twice as likely or half as likely to die if you had AD and got immune checkpoint inhibitor therapy. And they didn't really look at it in terms of like severity, but it is meaningfully suspected that is an important part of it. And so then I dug into this today because I was like, that does not make any sense to me at all, because I think of cancer as Th1 immunity, and Th2 immunity like smushes down your Th1 immunity. And here's what I found out. It turns out eosinophils, they are learning, have a very significant anti-cancer activity. And so there now is, so number one, eosinophils have anti-cancer activity. And number two, IgE is much more potent as a oncolytic something or other than IgG. And so now there are some reasons, and across the board, I guess it's been known for a while that people with AD tend to get less cancer than people without AD. But the immune checkpoint inhibitor thing, they think the other thing that's happening there is that the Tregs are acting as sinks for IL-2. And so when you've got a lot of Tregs, because apparently your body upregulates Tregs to try and control the AD. And I'm making all this up, by the way, in case anybody is like basic scientists out there. I was
like suspecting, but yeah.
Starting, okay. I could see Ferris twitching a little bit, so I didn't, but I did read up on this today. So the Tregs act as a sink for IL-2, and whenever you do immune checkpoint therapy, one of the things that happens is your Tregs go down. And when your Tregs go down, if you've upregulated your IL-2 because you had so many Tregs, now there's more IL-2, which is also anti-cancer. So it like there are multiple mechanisms by which being atopic might make you more responsive to immune checkpoint inhibitor. And it may be that the Dupy is a just marker of you have bad atopic dermatitis. So these mechanisms are even more operative in you.
Yeah, I thought it was like, it wasn't exactly contradictory, but it was like if you looked at your paper and you said, okay, having a sort of Th2 hyperactive immune system helps you fight cancer, Dupy is anti-Th2. So you would think, okay, well, like if we're going to be consistent between the two papers, it should show that Dupy actually makes cancer treatments worse. But it was the opposite.
Yes. And their takeaway was that, or the takeaway that I found when I was digging into this, that the EOs are probably the best explanation because Dupy is kind of pro-EO. Like we know that when you start on Dupy, you get a transient eosinophilia because IL-5 is the eosinophil one. And so Dupy doesn't block it at all. So it might be that it is almost stimulating the eosinophil part of your immune reaction.
Actually, there are, and I was looking, there are a bunch of like pretty much looking at Dupy in cancer treatments.
Yes.
Like a fair number. There's like 5 trials ongoing. They're like, we're just going to add Dupi to standard immune checkpoint inhibitor, right? I mean, we'll have the answer.
Those companies need to send me some checks because like a year ago, I was like, Dupy needs to do these. In fact, Laura's husband, for one of our listeners, is like in charge of cancer at the University of North Carolina. And I told her to tell him. So if there are any trials going on at UNC, I am taking full credit for that.
You got senior author status on every single one of them. You're good.
I
don't even know. I don't know if I told him. I talked to him about you a lot, but I didn't.
You'll be acknowledged. You'll be an acknowledgement.
We'd like to
that's more. That would make a lot more sense. I don't want to have to read the papers.
I do. I want to say, Dupi's used to treat COPD, right? So what do people with COPD? They smoke. They also get a lot of lung cancer. I do believe that there's better survival in lung cancer patients on Dupi. Or either that was a study somebody was looking at, or it's been shown. So like that will be a really interesting place to look at the Dupi cancer thing. We have looked at this a couple times. Like I think at the very least, we can feel pretty darn comfortable. Dupi does not increase cancer risk. If patients have cancer, we feel very safe having them on Dupi, whether it is to treat their side effects of immunotherapy or for their underlying disease, since they have like 11,386 indications for Dupi now. So I think that's
just generally good for you. That's all.
Yes.
Right. All right. Jump quickly to my other one. This one's just a fun one. Granuloma annulare. One of, I like looking for like weird treatments for weird stuff. So GA, there was a paper, hyperthermia for granuloma annulare. And basically, and I reached out to these Chinese authors to find out like the specific regimen that they used. So they use local hyperthermia, 44 degrees centigrade, which I think is like 120 degrees Fahrenheit or 110, 120. Patton, look that up. For granuloma annulare, pilot randomized controlled trial. So they did 30 minutes once a week on the most recently developed lesion. And they did like a randomized controlled trial, but there were like 4 people in each arm. So it like kind of counts. It was like stunningly effective. Like the pictures they have, it's like, wow. And so apparently heating up granuloma annulare makes it go away. And even some of the patients who had like widespread, one of them had widespread disease, and they got a lot of their widespread GA got better. It somehow affected the systemic immune response. So, right, if this was like a $10,000 thing, no, I wouldn't be like, oh, we should all be doing this. But you get a heating pad. From what I could tell when I looked it up, was basically set the heating pad to medium, put it on your GA lesion for 30 minutes once a week, do that for 3 months. Usually they were better within like a month. It was nuts.
So once a week heating pad. So maybe the full body. See, the problem is I saw somebody with GA today. I was like, I guess I'm just going to inject it because I had to work all day. You just sit and pick papers all day, and you didn't have them uploaded for me to read. I'm the only derm on drug who works on Mondays. I'm going to put that out there. And so
you need to get on some more drugs, Spirit.
Like, there's got to be something better.
I have a heart problem. I would like to point out.
That's true. You do have a heart problem.
Thank you.
You've got an excuse for now till you get surgery. Then I want.
Well, he's always had a heart problem. Now there's a structural problem with his heart as well.
Exactly. Okay. So then like, I think I remember seeing this paper. Like, I wonder if you put people in, like those saunas, right? Like full body,
sauna.
go to the sauna, infrared sauna.
Oh my gosh. For like the people with the widespread GA, that's genius. And you write them a script for it, and then they can use their HSA dollars to pay to go to the infrared sauna.
It was an infrared device that they said they used in the study.
Yeah, that's actually more literature supported than the heating pad.
And it's 112 degrees. And I do want to point out that one of the patients had a lesion on the penis. I don't know about that. I don't think I'd be like, yeah, heat it up.
GA.
Yeah,
maybe it was the syphilitic variant. But so that's it. Ferris, that's genius. The infrared sauna for widespread GA, because those people are a pain in the butt to treat. And for localized GA, just do a heating pad at home, the back of their hand, the top of their foot, whatever. They did just one lesion. They didn't do all of them, but it was impressive. Like, it was impressive, those pictures. Easy,
Yep.
cheap.
All right, everybody's got to try it now, and we're going to report back to see if it works.
Okay. All right. We're in. All right. Let's move on to our next paper. Dr. Ferris, what do you got?
Okay, I'm going on the kind of sort of AD theme, which is a paper in JAMA Dermatology, also out of, I believe, China's Zhu et al., safety and efficacy of ICP 332 for moderate to severe atopic dermatitis phase 2 RCT. Okay, what's ICP 332? This is a TYK2 inhibitor. You're like, well, don't we have a bunch of TYK2 inhibitors? This one's different because it binds to the JH1 catalytic domain. So everybody who's been to like a deucravacitinib talk or anything from like Takeda, you're like, you know, the word allosteric inhibitor, like, you know, the back of your hand. So you know that those don't bind to where the ATP binds. But this one's different. It binds to the catalytic domain. What does that mean? It binds, like, the catalytic domain is not just in TYK2, it's in JAK1, 2, and 3. So this drug does have some JAK1 activity, unlike the typical TYK2s, but it's like 40 times more selective for TYK2 than JAK1, but the other ones will be like we are 5,000 times more selective. So what's it doing? So it's kind of got like a TYK2 favored, it's like a TYK2 strong JAK inhibitor. And so this was a double-blind, placebo-controlled phase 2 trial, 19 centers in China. So it is all Chinese people. Their eczema, their atopic derm is probably different, you know, than what you see in like sort of the broad spectrum U.S. population. 75 patients total in the study, 25 per arm. So small study. Placebo, 80 milligrams and 120 milligrams a day. Primary endpoint, 4 weeks. Okay. So this is also like a super short study. It is, so, you know, what does that mean? Like the single oddball event can throw off the results, like the single oddball super responder, the weird, you know, whatever, AE. So the efficacy part's kind of interesting. At week 4, reduction in EASI score was 78%. And with the 80 milligram dose and 72% with the 120 milligram dose. Like that's a pretty darn fast, significant, easy response. Yeah.
Wow.
And it was 16.7% with the placebo. So not nothing, but like that's a pretty big difference. Okay.
That is the technical term,
yeah.
Dr. Ferris, is ginormous. That
Ginormous.
is a ginormous delta.
Yes, ginormous delta. Okay, how about EASI 75? The placebo adjusted EASI 75 response is 56%. And so if you look at like what that means, like EASI 75 of drug minus placebo. And so like, what does that look like for a JAK inhibitor? That's like kind of up there with like upadacitinibs at 12 to 16, 12. I think their primary endpoints are 12 weeks. So, you know, this is not a, you know, head-to-head comparison, blah, blah, blah. But like, it's pretty, you know, impressive. Common AEs, the things that you would expect. The one weird standout AE was decreased fibrinogen levels, which occurred in 24%. We never looked at that in our like JAK inhibitor studies that I could see. So I don't really know. Like, so in theory, I was like, what would decreased fibrinogen do? So, you know, we worry about like clotting events, but really decreased fibrinogen would maybe be associated with increases in bleeding. You know, but there wasn't like bleeding in here. It's just like, that was like their thing, decreased fibrinogen levels. So
weird.
There was one case of rhabdo in the 120 milligram dose. Interestingly, the 80 milligram dose seemed to work better than the 120, but 25 patients, we don't know what that means per arm. So there was one case of rhabdo, and like every single JAK inhibitor study, what did they say? Well, that person was really exercising a lot. So people in JAK inhibitor studies decide to take up exercising a lot. So that's really what it was. So, you know, small study, early time point. You know, I just think it's going to be interesting to see where this goes. And if you look at some of their other, like BSA, like decrease in BSA was like, from baseline, like 20, I'm trying to see what their baseline, I didn't like look at what their baseline was, but like while the baseline was by the decrease from baseline in BSA at 4 weeks was like 5% in the placebo group, it was like 25 to 30% in the active treatment in the TYK2 inhibitor group. Percentage of patients getting to like IgA 0/1 was like 36%. It's pretty good.
Mm-hmm. So mechanistically, this is pretty similar to brepocitinib. That's the dermatomyositis one that's very impressive.
That's like got JAK1 TYK2, right? Yeah.
Right. And that drug has been like spectacularly effective for dermatomyositis. So I wonder if like that mix of JAK1 and TYK2 is like some magic, you block those two and woo.
Yeah, it'll be interesting to see if they try that. I mean, even just TYK2, if you look at deucravacitinib, it's probably better in like connective tissue disease like lupus or dermato than it maybe even is in psoriasis. So, I don't know. I think it's interesting. We got a bunch of TYK2s coming out. Might they be the answer in atopic derm? Perhaps they will be. I will say that also in the study, they did like follow people after their 4 weeks. They withdrew the drug and then followed them. Itch went up, EASI score went back up, BSA went back up. Like they did. It wasn't a sustained, response, but they did. It also did what you would expect. So I just thought this was an interesting paper.
Don't companies freak out with lab abnormalities? Like, isn't that enough to like shut down a drug? There was a Bruton's tyrosine kinase inhibitor. I think it was fenebrutinib for CSU, and it worked great, but they were getting like these little bumps in LFTs, and the company was like, "Yeah, forget it. We're not even going to try." So I don't know. The low fibrinogen sounded scary to me, and it was in both. It was in both arms. It was in the 80 and the 120, and it was up to a quarter of patients.
Yeah, it's a high number. I guess I don't know enough about the clinical significance of that to know. And, I don't do all our TYK2 inhibitors do the same thing. We don't check it. And I've never seen, I went back to look and see do we have this in the deucravacitinib studies? It wasn't monitored. It was specifically monitored here. I think it was based on data from another study. So
yeah, that's the thing is there had to be a reason they're monitoring it because it's not like a normal thing anybody would be monitoring.
Yeah.
Yeah. Maybe it's measuring the synthetic capacity of your liver. Something like that.
Yeah. And their liver function otherwise was normal. So, it also made me, again, because we've got all these other TYK2 inhibitors around, but not being really pushed for psoriasis or in development. Like maybe atopic derm will be the next, frontier for them.
This segment about fibrinogen is making me think like if aliens were like listening to the podcast and we're like, these are the 3 dermatology experts in America. And we're like, fibrinogen, it could be, I don't know. Is it clinically relevant? What? Yeah, we're the experts. That's great.
As long as they show up on our Spotify metrics as listeners, it's all good. But if they don't have accounts, it doesn't matter. We don't need them.
All right, let's move on. Patton, what do you got?
All right, my second 6-pack, British Journal of Dermatology, March 2026, titled BAFF April Blockade with Telitacicept and Pemphigus foliaceus, 2 cases by Wang et al. So what are BAFF and April? BAFF is B-cell activating, I guess it's factor. There's 2 Fs, but it's called B-cell activating factor. So
factor, B-cell activating effing factor.
That's good. We'll go with that. It's also known as B lymphocyte stimulator, so it's sometimes abbreviated as BLyS, B-L-Y-S. April is a proliferation-inducing ligand, and BAFF and April are cytokines that bind to B cells, influencing their activity and survival. One of the receptors to which they both bind is known as TACI, T-A-C-I. So telitacicept is a fusion protein, Fc portion of an IgG, and the TACI receptor. And it sort of kind of sucks up BAFF and APRIL, the two cytokines, theoretically not allowing them to bind to B cells. So the paper reviews 2 cases of pemphigus foliaceus, 22-year-old female, 44-year-old female, both refused systemic corticosteroids. Like, man, pemphigus, like, I don't know how you could ever get a patient better not using systemic corticosteroids. So this is kind of monotherapy. They were both on minocycline. I don't really think the tetracycline antibiotics do much for pemphigus. One was also on some weird, like, Chinese medicine thing. Both patients were given telitacicept 160 milligrams weekly by sub-Q injection, and both patients improved. So PDAI, PDI, measure of pemphigus severity, dropped to 0 in both patients, one by week 8, one by week 10. That's pretty quick. And the anti-desmoglein 1 antibody titers dropped. One patient, they went from 596 down to 2, and the other one, it was 209 down to 2. So maybe a promising drug. I mean, it was kind of a dumb paper. I'm known for this. It's not FDA approved to treat anything. It is actually approved in China to treat SLE, rheumatoid arthritis, and generalized myasthenia gravis. So it's being studied for some autoimmune conditions. I think it got fast-tracked here for Sjogren's. And so maybe a promising future pemphigus treatment. I mean, it's almost like you do have to hit B cells, right? You look at rituximab, you hit B cells. This is kind of like a softer hit on the B cells, but maybe an effective therapy. So nothing that's clinically useful for anyone outside of China. So you're welcome and good night.
It's like a B cell tap.
For somebody who's looking to do a little medical tourism, just get on that 14-hour flight to China, and you get there, get your tepalaclinib.
That's exactly what it's called. Good. I'd like someone to go to China and ask for that. They'd be like, no, go back. We don't have that. There is no such thing. But Dr. Zires said.
Exactly.
I think I'm banned in China, to be honest. It's likely China and Iran. Those are my two. All right. We're moving on to my last two. So first one, just interesting. So this was a study out of, I believe, Indonesia, where they were looking at scabies, and then people who, after they got treated for scabies, how long their itch persisted. So relatively small study, reasonable chance that these people had like other stuff going on, whatever. But I'm pretty fascinated by this. So the main takeaway, people who had a long-term post-scabetic itch universally, well, not really universally, but had really high IgE at baseline. So you could measure IgE at baseline, and then that predicted very effectively that you were going to have a prolonged post-scabetic itch. And that's very plausible to me. So I think of it as being that, scabies mites were allergic to them. It certainly is possible that people who are atopic are driving more allergy to them, and it's going to take longer for the inflammation and the itch to resolve. If this was like a super hard test to get, yeah, I'd be like, meh, I don't know, or if it was expensive or you got to send it off or whatever. But this is easy. You do, an IgE test. If their IgE level is super elevated, you tell them, oh, this might take a while. Don't worry, So just thought it was interesting. Then the other one that was even probably more interesting to me, but it's mostly mechanistic, was about sort of a different approach to food allergy and atopic dermatitis. So the idea is that with chronic skin inflammation, high alarmins, so IL-33, TSLP, you drive, and this, I think Ferris has talked about this a little bit, you drive Th2 sensitization to weak allergens, especially in the gut. And so essentially you become cutaneously and maybe via gut routes sensitized to things like propylene glycol or propolis or whatever. And then that's driving a systemic Th2 inflammatory state that you could, in theory, get better via dietary avoidance. And this would go to some extent against my frequently repeated thing. Look, just put people on an IL-13 inhibitor, and if they get better, it was atopic derm. Well, no, if it's because contact derm is a Th1 disease. Well, but if there's this other type of Th2 contact derm associated specifically with systemic contact derm, that then Dupy would work for that. And then maybe those are people we could get better with a avoidance diet. However, my final take on the whole thing is if avoidance diets worked, we would not need statins and we would not need blood pressure meds. We would just say avoid, foods that are bad for you, and people wouldn't die of heart attacks. But instead, we have all those drugs, and we have cabbages, and we have caths, and the whole thing. So I'm still if you told me we could do all of this testing, and you do all of these avoidance diets, and be super careful with what you eat for the rest of your life, and you won't need to whatever, and it's going to take a year to figure out if you're one of those people, I would be like, just give me the Dupy. Don't care. I'd give myself a shot every 2 weeks, and if my insurance stops paying for it, then we can come back and try and figure this shit out. That would still be my take on it, but might not be everybody's take. Just an interesting thing. I'm not sure what to do, because kind of what they recommend is atopy patch testing, which is sort of a modified normal patch test. It's mostly they're patch testing people to different stuff, and you're reading the patch test a little bit differently, but nobody does this. There's probably 10 people in the country who do it. So unless other people start doing it, even if this is real, it's hard to figure out, other than doing empiric food avoidance.
Yeah.
Be my takeaway.
And there's no ordering a test to the food, right?
No,
it's so hard when people come in oh, look at this. I saw the allergist and I'm allergic to these 18 foods. They're
yes. Or even better, if they went
mites.
to the
okay, well,
yes, they went to the functional medicine doctor and got food IgG testing. And any allergist you talk to is IgG literally means you are not allergic to it. When you get IgG, that is specific. We test that to prove you're not allergic. But since it's a positive test, people get, whoa, I'm in a positive test to the, corn. Yeah. But so just mechanistically interesting. These guys, I've had a strongly held belief about this Th2 skewing stuff is baloney. They convinced me that it's at least possibly not baloney. I now give it real credibility that we could have this as another contributing factor to the rise in atopic dermatitis over the last 40 years. So
yeah, I mean, it does also kind of back up and we've had Peter Leo on and talk about the gut skin axis, and I was oh, the gut skin axis, but maybe it's real, right? There are some now explanations that there maybe, still don't know what I think about leaky guts, but maybe there is something to all of this.
Oh, I still think of the microbiome as the intestinal microbiome is the best, but that's maybe it's complicated. It's complicated. It's like our kids, not my kids, probably not you guys as kids either. It's normal kids' dating lives. It's complicated. That's what we'll go with. All right. We're ending the episode there. I want to thank everybody for joining us this week. I hope you learned a few things. Hope you laughed once or twice, but mostly we hope you're planning to join us again next week. And until then, I'm Matt Zyrus.
I'm Tim Patton.
And I'm Laura Ferris, and we are Derms on Drugs.